Prasad Eye Institute based in Visakhapatnam. Presently, Dr. Sachdev is a consultant ophthalmologist in pediatric ophthalmology and in neuro-ophthalmology, and he has an experience of 11 years now. His areas of interest are optic neuritis, including atypical optic neuritis, MS-NMO, IIH, neuroimaging, myasthenia, so on. And his major achievements are he has won several awards. He has the hypohomocysteine in isolated cranial nerve palsy. For that, he got an award. And he also got an award for treatment of non-arthritic ischemic optic neuropathy, intravitreal Avastin versus oral corticosteroids.
Yes. Thank you very much, sir.
He has 58 publications in peer-reviewed international journals. He has 10 book chapters, including textbook chapters in neuro-ophthalmology. He has done his clinical research fellowship in neuro-ophthalmology from Imora Eye Center, Imora University in USA. He has been the expert panel. For neuro-ophthalmology papers for AIUS and Andhra Pradesh Ophthalmological Society. He is the reviewer of AJO, BJO Ophthalmology, BMC Ophthalmology, IJO, JCRS, MEAJO, and he is the editor for BMC Ophthalmology, Pediatric Ophthalmology. I would like to welcome Dr. Virendra Sachdeva, who will be giving his presentation today on common neuro-ophthalmological conditions. A very warm welcome to you, Dr. Virendra Sachdeva.
Thank you very much, Dr. Satyajit, for this kind invite and kind introduction. I'm happy to be part of this PG learning course, and I hope that I can help you all learn a bit and share whatever I know. So I think we have sufficient time. If anything is there, you can all stop me or send in the questions so that we can discuss. And I will try to go topic by topic so that, and at the end of it, we can reiterate the point so that it's easier for everyone to grasp. If any point is there, you are welcome to share with me in between as well. So I'll go ahead with the presentation now. And the objectives of my presentation will be to focus primarily on the common optic nerve diseases. So we can classify them into diseases presenting with optic disc edema and those presenting with optic atrophy, and a little bit about miscellaneous conditions. And what I will be doing is that I will be sharing some tips in between. I have seen the program and I felt that there has been enough focus on diseases presenting with optic disc edema, and approach to optic disc edema has already been covered. So I'll not go much into details of how to evaluate optic disc edema, but we will try to cover more with the specific diseases and then approach to optic atrophy. Let's begin with a small clinical tip that most important thing in neuro-ophthalmology is possibly history. And possibly when all other investigations come out negative, still the history and revisiting the history in the context of the patient findings is the most likely thing that will give us the clues. So that's why we always say that possible focus history is the most important investigation in neuro-ophthalmology. So let us see this by this example. This patient is a 60 years old gentleman who was referred to us recently in July 2020. And this patient was actually having complaints of blurring of vision in both eyes from January 2020. The patient is diabetic, hypertensive, and the patient had biscorrected visual acuity of 20/100 in both eyes. Patient also had cataract in both eyes and mild NPDR. So at that time, the diagnosis was thought to be cataract along with NPDR, and the cause of poor vision was thought to be cataract. The patient underwent cataract surgery in left eye, and the patient continued to have poor vision in both eyes. The best corrected visual acuity in July 2020 was 20/160. At that time, optic atrophy was diagnosed and patient was referred to neuro-ophthalmology clinic. So this was the visual fields with which the patient came to us. We can see that there is a temporal hemianopic field defect in the right eye, as well as there is central scotoma extending inferiorly in the left eye. At this point of time, it was thought that it's a optic neuropathy and patient was sent to us. At this point of time, given all the findings, we went back and took the sequence of events. The patient gave a history that since 2019 July, patient was diagnosed to have pulmonary COX, and the patient was taking ATT and the decrease in vision happened in January 2020. Now, what is important? The patient was on ethambutol even in January 2020 when the decrease in vision started, and he continued on ethambutol until March 2020. Patient already was having an MRI brain with contrast, which was normal, and the patient was finally diagnosed with ATT toxicity. So the point I'm trying to stress over here is that the chronological sequence of events is very important. We go back and find out from the patient how the patient detected the poor vision and what was the context, what were the relevant medication history, what were the relevant systemic histories. They're very much important. So in neuro-ophthalmology, possibly this is very important. We go and keep our curiosity levels high, keep up the detectiveness high, and follow. Some of the people might be liking the suspense movies and the suspense novels, so follow that, and then we are on the path to detecting the etiology quite easily. So as we are going to discuss about optic neuropathies, I think it makes sense to make a small impression in our mind how we should evaluate a patient with optic nerve disease. So this will apply even to glaucoma, but in context of neuro-ophthalmology, some of the important points that we should keep in mind are important. So what you can do is that we always look at the optic disc in a stepwise manner. And the appearance, before we go to optic disc as such, we should first look into the way how the media is, if the media is clear or not, how is the adjoining retina. And then when you come to the optic disc, look at the size of the disc, shape of the optic disc, look at the margins, are they well defined, is there any abnormality there, color, especially that of the temporal rim, look at the blood vessels, look at the peripapillary RNFL. This is very important. As I will show through the examples, it will be very important in helping us make the final diagnosis, especially in patients who have a peripapillary RNFL obscuration in early papilledema, and look for any abnormal findings over the optic disc, and look for the blood vessels. Sometimes the blood vessels will give us the clue. I will again reiterate these points through the examples. So you can use this as a template. Look at the media, look at the retina, then come to the optic nerve, look at the size, shape, margins of optic disc, color, especially that of the temporal rim, blood vessels, peripapillary RNFL, opacification, abnormal findings over the optic disc. And if you have doubt, use the red free light that will highlight the changes quite easily. Okay. And so as we are going to discuss about the optic neuropathies, there are going to be two major patterns in which optic nerve can respond. Either it can degenerate and we can have patients presenting with optic atrophy. You can see that if we apply the entire template, the media is clear, you can see the retina is fine, but you can see that the optic nerve itself is showing the pathology and the temporal rim is quite pale in both eyes. Okay, whereas the blood vessels are appearing normal. So this is a case of optic atrophy, a common scenario that we will see in our clinics. And the other scenario is like it can swell. You can see very well that there is obscuration of the disc margins. Also, the blood vessels are obscured. What is important? Look here, the peripapillary RNFL is also obscured, which suggests that this is a true edema. So these are the two major patterns in which we will see the patients. As I was saying that the optic disc edema has already been covered, I'll try to highlight an approach to evaluating a patient with optic atrophy. So let me begin by asking you all a question. In a patient with optic atrophy, what investigation would you like to obtain first? How many of you would like to obtain visual fields? How many of you would like to obtain visual evoked potentials? How many of you would like to consider directly imaging, OCT? And lastly, if you were to reconsider possibly doing a focused history taking fundus examination and doing the visual fields at that time. So any guesses? Anybody would like to take that?
You can always unmute yourself like yesterday and you can discuss and answer.
Yes. So I'm trying to keep it interactive so that it does not become a monologue. We are not able to see each other, but at the same time, it will not be look like a monologue, and it will be interactive.
Correct.
Okay, so maybe you can all message your answers. Is there a chat option in this?
Yes, there is a chat box and they have written also, answered also.
Okay, maybe I am not able to see that. I'm sorry, I'm not able to see that. But I'm sure that many would have written the last option. Focus.
Conversation.
I'm sorry.
There's an icon of conversation. Extreme right, you have a red button. Next to that, you have participants. Next to that, you have a conversation.
Is it not showing me because I'm in the slideshow mode, or? Yeah. Okay. I'm sorry, I cannot see it. I'm relatively new to using this app, this platform, but in Zoom it shows up easily. No worries. I will minimize and then I will see in between. I'm sure that.
So possibly in the full screen, na, when you are making it in the full screen, it might not show you the slide bar.
Yeah, I think so.
Possibly that, yes. So
Yeah.
whenever the message is coming, the automatic pop-up will be there, sir, which you
Yes.
can.
Very good. So yeah, I minimized and I've exited the full screen mode. I can see that many people have written the last option, that is focus
Yes,
history taking, fundus examination and visual fields. Yes, so that is very important. And then let's see it with the help of examples and develop an approach to evaluating a patient with a optic atrophy. Okay, so I'll continue with the presentation. I would like to stress here that in many textbooks, we see that we classify optic atrophy as primary optic atrophy, secondary, consecutive, glaucomatous, and cavernous. This classification was developed based on the morphological appearance of the optic nerve, but at the same time, it does not really convey the underlying etiology. For example, if you have a patient with optic neuritis and patient develops swelling of the optic nerve like papillitis, the patient will have a secondary kind of optic atrophy. Whereas if the patient develops retrobulbar neuritis, patient will have a primary kind of optic atrophy. But the etiology is the same. So what many people propose is that it's better to classify according to the underlying etiology. You can classify as traumatic and non-traumatic. And the traumatic will be called as post-traumatic. The non-traumatic ones can be post-ischemic, post-neuritic, post-compressive, and consecutive optic atrophies, which are common examples. And of course, there is glaucomatous optic atrophy. When you see a patient with optic atrophy, keep in mind that it could be just be an optic atrophy mimic, and it's not necessary that this patient is actually having a optic atrophy alone. For example, if you see the picture on the extreme left of your screen, this is actually appearing like a very pale disc, but this is a magnified picture of a patient with optic nerve hypoplasia. And if you see carefully, the optic nerve is actually much smaller, and you can see a double ring sign. You can see an area of a whitish ring outside the optic nerve itself, which is the area where the sclera is visible to us and optic nerve has not developed. The second example in the center is that of a optic disc coloboma. And you see the rim all around the optic nerve, the rim appears to be quite good, but at the same time, you can see that there is actually an area of excavation where there is no tissue which is visible, and it's appearing like a excavated optic nerve there. And if you see the blood vessels, they are not visible in the center, but they are coming out from the edges of this excavation. This is an example of an optic disc coloboma. This example is very common. You can see in many myopes, the disc is tilted and there is peripapillary chororetinal atrophy. And this might be mimicked, may be thought of as a optic atrophy if you are looking just with the 20D lens and you are not taking a magnified view. All of these, if you look carefully with a high magnification, for example, with a 90D lens, or you take a fundus photograph, you will be able to decipher the underlying cause. So how do you approach? Keep that optic atrophy is not a final diagnosis. It's a sign that you are going to evaluate. We should not obtain MRI brain and orbits as the first thing. Look carefully whether there is disc pallor or it's a congenital optic disc anomaly. If there is an optic disc anomaly, then we are looking at something else which could be part of a systemic syndrome. If not, we are looking at a patient with optic atrophy. We should keep in mind 3 P's. Look at the predisposing factors, how the situation started. Like in the first example, there was history of taking ethambutol. Are there any precipitating factors? For example, the patient is actually a diabetic and hypertensive, and patient had an acute loss of vision. And at that time, there was a history of acute fluctuation of blood pressure. It could be a post vascular occlusion kind of optic atrophy. We should look for acute or insidious kind of vision loss. And then in the examination, come back to look for some special patterns of the optic atrophy that I will highlight, and then do tailor-made investigations. So let's see a common scenario. This is a most common scenario of optic atrophy. Patient is referred to you for evaluation for temporal disc pallor. But let's go by the history. This is a patient who is a 24-year-old woman referred to us for blurring of vision and optic atrophy evaluation. Visual acuity is 20/30 in right eye and 20/60 in left eye. There is history of febrile illness preceding the vision loss, but there was no relative afferent pupillary defect because of bilateral involvement. Also, we can see that bilaterally the color vision is subnormal. This is a visual field of the patient which shows that there is a central scotoma in both eyes. And at the same time, the VEP of this patient showed the amplitudes were, the waveforms were reproducible until the small sizes in both eyes. But at the same time, the P100 implicit time, that is the time taken from the starting of the recording till we reach the peak of the P100 wave, is prolonged. This is 138. Normally, it's around 100 plus minus 2 standard deviation, and each lab gives its own cutoff. In our lab, our cutoff is 120. So this is definitely prolonged in both eyes. So this patient is most likely having a demyelinating optic neuritis. As I said before, the chronological sequence of events is most important. And in this second, in a similar setting, if we had a patient presenting with this history, we would think of toxic optic neuropathy. Sometimes family history is very important. And then if we are looking at a patient who had a sequential vision loss and there was presence of initially a mild disc edema and the patient later presents to us with subnormal vision and pallor like this, we could be dealing with a Leber's hereditary optic neuropathy. So how do you differentiate a patient presenting to us with a temporal pallor? The first example is that of a young patient with acute onset febrile illness and temporal pallor with most likely a postneuritic optic atrophy. If it is a sequential involvement in a young male and vision is quite subnormal like 20/100, 20/200, think that you could be dealing with a Leber's hereditary optic neuropathy. If the patient had a gradual onset vision loss, his vision is relatively good, 20/60, 20/50, 20/80, and is a strict vegetarian, what you should be thinking? Patient could be having a nutritional optic neuropathy that is causing the optic atrophy. And this is a reversible, partially reversible cause, or at least a modifiable cause where we could prevent further vision loss. And then we saw the first example where it was acute onset while being on a toxic medicine like ethambutol, we could be dealing with a toxic optic neuropathy. So we see in the same shades of temporal pallor, we can see at least 4 different kinds of etiologies. Now let me draw your attention to one more important cause. This patient has again presented to us for evaluation for temporal pallor. But look at the setting of the patient. This is a 30-year-old male presented to us with poor vision in left eye and was referred for temporal disc pallor. Visual acuity was 20/30 in right eye and 20/60 in left eye. There is a significant pallor in the left eye and mild pallor in the right eye. And you see that it is slightly asymmetric. The blood vessels are still quite preserved. But when we obtain the visual fields of the patient, we can see a bitemporal hemianopic field effect. You can see that there is a temporal field effect which is respecting vertical in left eye and in the right eye. Left eye is slightly worse than the right eye. And then if you this patient, you will localize the lesion to be near the cellular area or optic chiasm, and then you obtain a neuroimaging. Most likely you will find a tumor in the cellular area, either a pituitary tumor or a craniopharyngioma would most likely be the diagnosis. So such patients definitely need a neuroimaging. So the caution here is that if you are seeing a temporal pallor and a bitemporal hemianopia, localize your pathology to be close to the optic chiasm and obtain a neuroimaging. There can be other patterns also in a patient with cellular lesion. There could be a bitemporal hemianopia. There could be an incomplete incongruous hemianopia if the chiasm is prefixed. And if the chiasm is post-fixed, there could be optic nerve kind of field defects. And do not forget that there could be a junctional scotoma where there is an optic nerve kind of field defect in one eye and a temporal hemianopic field defect in one eye, which is due to the damage to the junction of the optic chiasm and the proximal optic nerve. So keep this in mind. So this is all about evaluating a patient with temporal pallor. Now we move to another pattern. Now you see this patient with optic atrophy. there is a diffuse pallor over here, but in addition to that, you can see that blood vessels are showing significant narrowing. This is highly characteristic of optic atrophy secondary to a vascular insult. For example, a central retinal artery occlusion, where in the acute phase we would have seen an edema and cherry red spot, or status post NAION, where there is a definite occlusion of the posterior ciliary circulation. If you see something like this, you should not obtain neuroimaging, but obtain evaluation for the vasculopathic risk factors. Another important pattern is that of a optic atrophy, where you see that there is pallor, but in addition to that, there is attenuation of blood vessels, and not only that, you can see that the peripapillary RNFL shows significant pigmentary changes. This pattern is highly suggestive of the fact that the patient actually had a disc swelling which has gone into optic atrophy. I think due to the correction, you cannot appreciate the pallor much, but actually the patient had more pallor. I tried to change the contrast and then it is not showing up so much now. But when you see a patient with a grayish-white pallor, blurring margins, attenuated blood vessels, and peripapillary pigmentary changes, think that the patient had post-papillary edema, optic atrophy, and it could be due to space-occupying lesions in the posterior fossa, hydrocephalus, diffuse meningitis, or chronic IIH. And the last pattern that is there is a patient with an optic atrophy with retinal lesions. Here, if you see, you can see mainly the temporal pallor, but you cannot see much other changes. Maybe there is very mild attenuation of the retinal arterioles. But if you see the fundus as a whole, so you can see that there are multiple chorioretinal lesions which are in the fundus mid-periphery as well as in the posterior pole. So this patient is also having a consecutive optic atrophy. This slide tells you the 5 different patterns that we see in a patient with optic atrophy. You can see a temporal pallor, which is suggestive of nutritional, toxic, hereditary, or a post-neuritic optic atrophy. You can see a optic atrophy with retinal lesions, which is suggestive of consecutive optic atrophy. You can see optic atrophy along with presence of sectoral pallor, attenuated blood vessels, which is significant about a post-NAION kind of optic atrophy. Then you can have an optic atrophy in which you can see blood margins as well as you can see peripapillary pigmentary changes, which is suggestive of a compressive optic atrophy or optic atrophy secondary to the papillary edema, and post-vascular occlusion where you see diffuse attenuation of blood vessels. So these are some of the common patterns that you should keep in mind that will help you in the clinic. The most important investigation after taking the history, doing a complete eye examination is visual fields. A central or a centrocecal scotoma is suggestive of optic neuritis, toxic, nutritional optic atrophy, and could also be there in a LHON, but the scotomas are bigger in those. Presence of an inferior altitudinal field defect is highly suggestive of ischemic optic atrophy, and sometimes the macular ganglion cell IPL OCT can give us some specific clues. For example, in the picture to the right side of screen, you can see that the superior segment is thinned out, and there is a corresponding inferior field defect, which is highly suggested that the patient had a post-NAION kind of optic atrophy. And in a patient with pituitary tumor, you can see that there is thinning of the nasal half of the MGCL IPL analysis, which corresponds to a temporal hemianopic field defect or a bitemporal hemianopia. This is highly suggestive of compression due to the chiasmal lesion. So this is what I would like to stress over here in various patterns of optic atrophy. Keep in mind that you do a focus history taking, look at associated symptoms, do focus examination, look for fine findings, and then make up your differential diagnosis and then do the investigations. This is all about the evaluation of a patient with optic atrophy. If anybody wants to ask any questions here, I can stop and we can take it here. Okay, so there is a question here why nutritional and toxic causes cause temporal disc pallor. So this is very important question. In majority of the patients where you see temporal disc pallor, nutritional, toxic, and hereditary, the lesion is actually happening because there is damage to the papillomacular bundle. The papillomacular bundle of the retina is having a relatively higher oxygen demand because this is the area from where you are seeing, right? Macula is the most sensitive area. So keeping that in mind, we are likely that if any toxic substance goes, if there is a nutritional deficiency, if there is a hereditary optic neuropathy, these cells are likely to get much more affected. If you see the mechanism of all of these, the mechanism is damage to the oxidative phosphorylation pathway. So because the demand is more here, these are going to get more affected. That's why you will see damage to these fibers as well as temporal disc pallor. Okay. I do not see any other question in the chat, but if anybody wants to ask anything now, we can take. Otherwise, we will go ahead. Dr. Satyajit, and you see anything? Anybody wants to ask anything? Okay. So in interest of time, possibly we'll move ahead. Now, I see that I have seen the schedule again, and then I saw that there is a important evaluation of the patient in neuro-ophthalmology talk has been already covered. But just to reiterate some important points is that RAPD is one of the very important aspects in a patient with afferent pathway disease. So I want to reiterate three important pearls in evaluating a patient for RAPD. We need to have dark room so that the diffuse illumination does not cause a false reflex. We should look at a distance target. The patient should not be looking at a near target so that accommodation is not stimulated. And then you should do a 3-second swinging flashlight technique. What does it mean? You count 1, 2, 3 while stimulating the eye. Why? Because this much is minimum needed, and if you stimulate more than that, it will blanch the pigment in the eye you are stimulating, and it might artificially induce a RAPD. Okay, so if you see in this video, we are using a pen light and we are stimulating both eyes. You count 1, 2, 3, and then do a swinging flashlight test. As you are moving the light from the right to the left, you will be able to see that there is dilatation of the pupil. So this is suggestive that there is a definite relative afferent pupillary defect. And if there is subtle RAPD, how will you pick it up? What you can do is that you can look at the first response and compare the speed of constriction. So you see the light response in the right eye and the left eye. If you see that it is appearing to be asymmetrical response, one eye is faster than the other, then it is suggestive that the eye which has a slower response is likely to have a RAPD. What do you do next? You use the neutral density filters. This is how a neutral density filter looks like. It comprises of bars of special photographic filter, which is going to reduce the light going inside. So which eye you will keep? You will keep in front of the normal eye. If you are suspecting RAPD in left eye, you keep it in front of right eye. And now you do the swinging flashlight test. If there is a RAPD, you will see that the response will start becoming normalizing as you are keeping in front of a suspected normal eye. And the point at which it becomes equal in two eyes is the level of the RAPD that you are going to get. How will you look for RAPD in a patient with only one functional pupil? So to look for a RAPD in only one functional pupil, we use consensual reflex in the eye with the normal pupil. And it is also called as RAPD by reverse. This is an example of a patient with traumatic optic neuropathy. The patient had damage to the right eye. Patient also has traumatic mydriasis, and we want to elicit whether there is a relative afferent pupillary defect or not. The right eye is fixed pupil, whereas left eye is the normal pupil. So what do? You take two light sources, you keep one below the chin, and the other one you use a focus light source such as pen light, and you will do the swinging flashlight test. Keep on looking at the response in the left eye as I will show in the video. You can see that as I'm stimulating the right eye, there is not much response. I'm stimulating the left eye, there is good response. Now again, I'm taking from the right to the left, pupil constricts, and if I take from left to right, pupil dilates. So through this technique, you can elicit the pupillary response RAPD when we are seeing the patient with only one eye good pupillary, only one eye pupil is functional. Okay. Now we move to diseases presenting with disc edema. We should remember that disc edema is again one of the morphological presentations of various optic nerve insults. And appearance depends upon the type of insult that happen. So it could be like a mild disc edema, severe disc edema. It could be a resolving disc edema, or disc edema along with peripapillary RNFL obscuration. How do you distinguish? Can you, just looking at morphology, tell us? There are some clues. In a patient with optic neuritis, disc edema is mild, but there will be profound vision loss. Again, in NAION, there could be significant disc edema. Along with that, you will see attenuation of blood vessels, and you might see some hemorrhages. And in a patient with AION, you will not only see that there is attenuated blood vessels, but also there will be diffuse pallor of the disc. Okay, it will appear like chalky white in acute stage itself. Whereas in patients with papilledema, the disc is massively swollen, and you can see presence of vascular signs that I will highlight little later. And in addition to that, the vision might be relatively preserved. But when we see a patient with disc edema, you are always concerned whether it's true or pseudo disc edema. So how do you distinguish? The picture on the right side of your screen shows a patient with a pseudo disc edema. You can see that there is blurring of the disc margin, especially on nasal side. There is some elevation here, but the blood vessels are going over the elevation. They are not obscured. Whereas in the patient on the left side of your screen, you can see a patient true disc edema, and there is hyperemia of the disc, there is presence of soft exudates, there are hemorrhages. You can also see that peripapillary RNFL is obscured. So this massive swelling is easy to distinguish in a patient with true disc edema. However, in early stages, it might be only the fact that the nasal margin will be showing obscuration of the peripapillary RNFL, and also the blood vessels will appear to be discontinuous as they cross the disc margin. Keep that in mind. This is again an example of a true disc edema. You can see peripapillary flame-shaped hemorrhages, pattern folds, cotton wool spots, and hard exudates. These are vascular signs that will help you distinguish true from pseudo disc edema. Now, I would like to ask you all which investigations are helpful in detecting disc drusen, which is one of the common causes of pseudo disc edema. Is it B scan, autofluorescence, OCT, FFA, or a CT scan? So let's see in the chat quickly any answers. So somebody says fundus autofluorescence, somebody says B, somebody says FFA. Yes, so actually all of these can be used, but if you want to pick up one single investigation, which investigation would you like to use? Possibly it is the B scan. The reason is that the B scan is very sensitive, and this sensitivity is higher in picking up even the buried disc drusens, which autofluorescence may not be able to pick up. Therefore, it will be easier. At the same time, the B scan can also give us an idea that whether there is presence of fluid around the optic nerve while you are doing the B scan, but it's a operator dependent technique, and you need to use low gain settings as well as learn the technique for detecting fluid around the optic nerve. If you are still not confused, you have a doubt, you can always go for fundus autofluorescence, where you can go for FFA, where in a patient with a disc drusen, you will be seeing either no staining or no hyperfluorescence, but in a patient with true disc edema, you can see a massive leakage, especially in the late phases, which will be quite helpful. Okay, so let me go for the full screen mode. Okay, this slide shows the various investigations which can be used. You can use a fundus photo, and you can see a slightly irregular or a lumpy bumpy appearance, especially here. You can see B scan at a low gain. You can see autofluorescence, and in a CT scan, you can see the hyperreflective spot at the optic nerve head. You can also do a EDI OCT or a enhanced depth imaging OCT, which is a special technique which helps us take the scan from the deeper layers of the optic nerve and the choroid, and you can see these round oval lesions which are present in the optic nerve substance at the same level as the hyperreflective spot seen on the B scan. This is highly suggestive that these are the drusens which are present over there. Important point to remember in a patient with disc edema is that if you are dealing with a patient with disc edema, is it papilledema or disc edema? Papilledema refers to disc edema which occurs only with increase in the intracranial pressure. For example, in a patient with IIH, CSVT, or a brain tumor which caused a compression of the CSF outflow. Whereas disc edema is a generic term which refers to disc swelling irrespective of the fact that whether there is increased pressure or not. So there could be retinal causes also. So let's see some of them. You can see a CRVO here, and you can see a presence of disc edema along with some hyperreflective spots here. So this patient is actually having a VKH syndrome. So these are magnified view of the other eye of the same patient, which shows that presence of hyperreflective spots in the outer retina and choroid. There is a shallow elevation of the retina, which is seen in a patient with VKH. And on the picture to the left side of your screen, you can see a patient with disc edema, along with presence of markedly attenuated blood vessels, hemorrhages, hard exudates, soft exudates. What do you think? A patient with malignant hypertension. So clues from the neighbor are very important. When we are dealing with diseases of the optic nerve with disc swelling, there are three important things that you are going to see. Either a pseudo-disc edema, we discussed about it. We discussed a little bit about papilledema. And then the other thing is an acute optic neuropathy. How do you distinguish between the three? Most of the time, pseudo-disc edema patients are asymptomatic. They have relatively good vision, good color vision, and they may not have any visual symptoms. It might be detected during a routine examination. Visual fields are either normal or might show only a nasal depression. Whereas in a patient with papilledema, you will see that they have complaints like gradual onset, insidious, blurring of vision. They might have transient visual obscurations. They might have normal color vision and might have even enlargement of the blind spot on the visual fields. In contrast, in an acute optic neuropathy, there is an acute change in vision. They might have subnormal color vision, and the fields show usually a dense scotoma. So the actual presentation of the patient helps us distinguish between them. In a patient with bilateral papilledema, you are suspecting a problem usually in the brain. Okay, so it could be a diffuse meningitis. You can see a patient with tubercular meningitis with exudates. You can see a patient with IIH, or you can see a posterior fossa tumor. But do not forget grade 4 hypertensive retinopathy, because it does not need investigation but an urgent referral to a physician to take care of the blood pressure. So look at the patient's picture as a whole, as I highlighted before. Look for hemorrhages, soft exudates, hard exudates, and most importantly, attenuated blood vessels. Sometimes we will see only attenuated blood vessels as the earliest sign of accelerated hypertension. Now we'll cover in brief about few important diseases with disc edema. One of them is IIH. So when do we suspect a diagnosis of IIH? IIH is a relatively common disease. You should keep high in your radar when you are seeing a bilateral disc edema. You suspect it in young patients, obese, relatively more frequent in women, actually much more frequent in women, and those who have a history of taking some exogenous substances such as vitamin A, tetracyclines for a long period of time. They usually have headache, transient visual obscurations, might have diplopia, they might have tinnitus. And how do you ask for TVOs, transient visual obscuration? You ask the patient, is there any blackout as they stand up from the sitting position, which is postural change. Headaches are also usually high pressure headaches. What do you mean by them? They're present throughout the day and they become worse when the patient bends forward. The patients usually have a marked disc edema. The vision will be good, but the swelling would be massive in majority of them, and they have a normal visual function. Even if visual acuity might be good, they might have relatively good visual fields also. Such a patient you should keep IH high in the mind. These patients, if you obtain a neuroimaging, they will be reported as normal neuroimaging. But it is important to remember, they have some signs which are very important. These are the signs of elevated intracranial pressure, such as empty sella. What is empty sella? You see that there is a concavity in the sella turcica. So it is a fluid filled, it is not actually empty, but it is filled with the meninges which have dipped into the sella turcica. Then you can see that there is flattening of the globe, there is perioptic nerve sheath dilatation, which can be seen both on axial views as well as on the coronal views. And then if you see the venogram, they will have stenosis, or they will have occlusion of the sinuses, especially the transverse sinuses, which is due to the compression from the elevated intracranial pressure. In these patients, MR venogram is actually mandatory to rule out a cerebral sinus venous thrombosis. You make a diagnosis by doing a relatively normal imaging, except for signs of elevated intracranial pressure, and doing the CSF analysis is the key. It should be normal CSF constituents, but pressure should be high and proteins might be low normal. These are the modified Dandy criteria, which I think most of you know. What is important is that patient is relatively normal, but there are signs of only headache and there is papilledema. CSF opening pressure is increased, that is more than 250 millimeters of water in the lateral decubitus position. Patient should be alert and awake. There are no localizing signs except for the cranial nerve palsies, that is lateral rectus palsy, which can be bilateral. And then there are normal CSF constituents, normal brain imaging with no evidence of venous obstruction. This is very important, otherwise you will miss the diagnosis. And there is a benign course except from visual deterioration. So once you establish a diagnosis of IIH by doing an imaging as well as doing a CSF analysis, you have two options: medical management or surgical management. Medical management is the preferred in majority of patients if they are having good visual fields and they are willing to comply. Yes, so example is, you see a visual field here. There is hardly a small enlargement of blind spot here, but very good visual function. Such patients are good candidates for medical therapy. In contrast, if you're seeing a patient with advanced field loss at presentation, these patients are at high risk of vision loss. You should do a close follow-up as well as do a further initial planning for surgery, which could be either in form of a CSF diversion procedure, either a VP shunt or a thoracoperitoneal shunt, or you can do a fenestration, especially if there is a rapid visual field damage. At this point of time, I would like to say that these are important points about IIH, but do not miss this disease. This is very, very important. I will highlight this with this example. This is a 50-year-old man who was referred to us as a case of bilateral disc edema and was diagnosed with bilateral NAION in setting of malignant hypertension. Patient did have a recording of BP of 210 by 110 millimeters of mercury 1 month ago. You can see massive edema in both eyes. You can see few colloid bodies on the surface of disc. There are few hemorrhages. Blood vessels are definitely attenuated, which suggests that this could be a malignant hypertension. But what is important? Look at the magnified view. You can see some pattern folds over here, and there is obscuration of the peripapillary RNFL, which suggests that this could also be elevated ICP. So we did go ahead and we did the imaging. We can see partially empty sella, as well as the MR venogram actually showed that there was a thrombus in both sides of the sigmoid sinuses and transverse sinus junction, suggesting that this patient had a cerebral sinus venous thrombosis, and the patient was treated appropriately both with anticoagulants as well as with Diamox, and over a period of time patient symptoms resolved and we could save the vision of the patient. And sometimes it could be challenging. So for example, like this, you can hardly see that there is narrowing of the sinus. This is a hypoplasia. But if we do a MR venogram with contrast, you can pick up the thrombus within the transverse sinuses. So dedicated workup is needed for these patients with serious VT. So these are important points about bilateral disc edema, IIH and CSVT. I would present a little bit very briefly about unilateral disc edema and then few important common diseases of unilateral disc edema. Now this is when you see a patient with unilateral disc edema, there could be, think in your mind where it could be unilateral. It has to be in the optic nerve, retina, or it has to be in the orbit as the most common localizing points. So it could be a pseudo disc edema which is presenting like this. Look carefully whether there is, how are the blood vessels at the margin of the disc. If it is true disc edema, look for optic nerve diseases, for example optic neuritis, NAION, optic nerve tumors, or neuroretinitis. And if you are looking not if the optic nerve is involved, do not forget that you have to look at the adjoining retina. Look for causes of intraocular inflammation like sarcoidosis, multifocal choroiditis, serpiginous choroiditis, which can present with unilateral involvement. Very, very rarely it has been described that patients with CNS disease or a systemic disease can have only unilateral disc edema. For example, unilateral IIH, unilateral disc edema in CSVT and ICSO. This is to be kept in mind only when these are ruled out. More commonly, a unilateral disc edema could be due to a Foster-Kennedy syndrome or a pseudo-Foster-Kennedy syndrome. What it means, one eye has gone into optic atrophy, whereas the other eye is still showing edema. So classically it was described with the frontal lobe tumor, which was causing compression of the optic nerve on one side, but then increase in pressure happened and the other eye swelled up. But more commonly it is seen in sequential optic neuritis and sequential ischemic optic neuropathy, where one eye gets involved first and goes into atrophy, whereas the other eye develops disc edema and presents with acute vision change. So keep that also in mind. In a patient with unilateral disc edema, you are focusing on primarily the optic nerve, intraocular pathology, and orbital disease. But sometimes systemic disease might be there. Whereas in bilateral disc edema, you are looking at increased intracranial pressure, diffuse CNS process, and systemic diseases. This is a very useful algorithm in evaluating a patient with papilledema. When you're looking at a patient with papilledema, rule out pseudo-disc edema, papilledema, and keep in mind whether it's an optic neuropathy, that is with vision change. If it is an optic neuropathy, we'll do a suitable workup. We'll discuss a little bit in brief, a little bit in more detail later on. And if you are looking at papilledema, you should obtain acute neuroimaging to rule out a mass intracranial space occupying lesion or intracranial mass lesion, hydrocephalus, meningitis. Look for the signs of meningeal enhancement. If you have anything like that, then we refer to a neurologist or a neurosurgeon and do appropriate workup. If nothing is there, we should look and rule out the possibility of a IIH. These are the important things that you should always keep in mind while working up a patient with papilledema. Okay, so at this point of time, I would like to ask you all if you all have any important questions, we can address them, and then we can go towards some important diseases. Any queries? You can type in.
Sir, what is the difference between Foster-Kennedy and pseudo-Foster-Kennedy?
Yes. So the question is, what is the difference between Foster-Kennedy and pseudo-Foster-Kennedy? The Foster-Kennedy syndrome was described actually with the olfactory groove meningioma. So these patients went on to have an optic atrophy on the same side where the meningioma is there, whereas when the patient's meningioma became larger and obstructed the CSF flow, it caused a hydrocephalus, and the patients developed the elevated intracranial pressure, which manifested as disc edema on the other side. In contrast, pseudo-Foster-Kennedy syndrome is a similar appearance, but not in presence of a brain lesion, but due to the optic nerve pathology. So the common diseases are the optic neuritis and non-arthritic anterior ischemic optic neuropathy, because they can happen again in the fellow eye of the patient. That's how it is there. Is it clear?
Yes.
Okay, good. So with this, we'll move to looking a little bit about optic neuritis. So I'll highlight this with help of some important examples, what we should be knowing in a patient with optic neuritis. We know that optic neuritis is the inflammation of the optic nerve. It can present either as retrobulbar neuritis, papillitis, or neuroretinitis. In retrobulbar neuritis, the fundus looks normal. In papillitis, there is swelling of the optic nerve, and in neuroretinitis, there is not only a swelling of the optic disc, but there are presence of hard exudates which are radiating in the form of a macular star or a macular fan towards the macular area. The neuroretinitis disease has a different etiology, and it is not related to demyelinating kind of optic neuritis, whereas retrobulbar neuritis and papillitis are highly suggestive that the patient is having a demyelinating disease. So what are the demyelinating diseases we are thinking about? It could be an isolated demyelination which is affecting the optic nerve, or it could be demyelination in association with a CNS or a systemic disease. It is also common, especially in our country, we see that post-vaccination or a para-infectious kind of demyelination. Body is responding secondary to the infective agent and develops a demyelinating response. So we try to subclassify optic neuritis as isolated demyelinating optic neuritis or optic neuritis in setting of certain important diseases. Most important of those are MS, neuromyelitis optica, and recently diagnosed MOG optic neuritis. So we'll see some examples of these. But before that, in all of these, the common pathology is that there is damage to the myelin sheath of the axons. We know that myelin sheath is an insulator and helps in saltatory conduction, and the patients will have a good fast conduction if the optic nerve is well myelinated. Whereas in the patients who have a demyelination, there is damage to the myelin sheath and the conduction stops. And depending on how much damage is there, it might be complete stoppage and patient may not be able to perceive light. Whereas in patients who have partial deficit, there might be a slow conduction in these patients. So let's see how it can present. It can present as a typical optic neuritis, that is inflammation of the optic nerve secondary to demyelination, which is either isolated, post-vaccination, or in MS. These patients tend to have a subacute decrease in vision, pain on eye movements, and dyscometopsia. But there is spontaneous improvement that starts 2 to 3 weeks later. Even if we don't treat, they will have improvement. And there is no further decrease in vision. I'm sorry, I think the slide got mixed up. So yes, so in a typical optic neuritis, there is a acute loss of vision which worsens over a period of 1 week, but in second and third week, improvement in visual acuity starts. And by 6 weeks, the high contrast visual acuity is usually good, more than 20, 40 or so. How do we investigate a patient? Majority of these patients need MRI as a first line investigation. The idea is to rule out some other pathology such as a space occupying lesion, but more importantly to find the damage in the optic nerve in the brain, and it's a predictor of what is the underlying disease that is there. What we obtain is MRI brain and orbits with contrast in all patients, and we should obtain special sequences which will help up because the lesions in the periventricular areas. And if it is a recurrent optic neuritis, we also obtain a MRI spine. This is what you will see in a patient with a classical optic neuritis. You can see that there is presence of this patient has optic neuritis in the right eye, and you can see that as compared to left eye, this optic nerve is enlarged, thickened, and on administration of contrast, there is increase in the brightness and enhancement of the optic nerve. In addition to that, there might be some other pathologies. So this is an example. This previous example was that of a patient who had a typical optic neuritis, but there was no other brain lesion actually. So this patient has an isolated optic neuritis. In contrast, I'll highlight another example. This is a patient who is a 25-year-old woman who presented to us with subacute decrease in vision in left eye for 1 week. The patient denied frank pain or pain on eye movement, but there was periocular discomfort. There was no other significant history, no fever, no vaccination, trauma, recent travel, but there was no other body weakness as well. The patient's picture appears like this. You can see that there is presence of the temporal pallor of the optic nerve in the right eye. There is mild hyperemia of the optic nerve in the left eye. And if you see the color photo, you can the red-free photo, sorry, you can see that there is hyperemia here, but there might be minimal pallor in the left eye as well. The patient's color vision was affected in the right eye, and the visual fields also showed nasal depression in the right eye. If we see the visual evoked potentials of this patient, you can see that in the left eye we have a extinguished pattern VEP. We cannot see the response even to the largest stimulus, whereas in the right eye we can see that it is present up till the medium size stimuli, but it is extinguished for the smaller size, suggesting that there is bilateral pathology which is going on in both eyes. So this patient actually in the VEP we could not still elicit the prolonged P100 implicit time, but when we obtained imaging, we saw that there is thickening of the optic nerve along with enhancement on post-contrast images. And in addition to that, the brain MRI was also abnormal. It showed presence of hyperintense lesions in the periventricular area, which are arranged perpendicular to the corpus callosum. These are called as the Dawson fingers because they are arranged along the medullary veins, which are going perpendicular to the corpus callosum. This is highly suggestive of a patient with a multiple sclerosis. If you see, how is this case different? There was pallor in both eyes, which suggested that this is not the first episode. The patient actually did not have RAPD because both eyes were affected. There was subclinical involvement in the right eye, and there were MRI lesions not only in the optic nerve but also in the brain. So this was a patient with a recurrent optic neuritis and brain lesions, which is highly suggestive of multiple sclerosis. Now I'll highlight another scenario which we should know in a patient with optic neuritis. This is a patient who had been diagnosed with multiple sclerosis but presented to us in 2011. This is a relevant past history. In 2003, patient had a non-compressive myelopathy and the patient improved with IVMP. 2004, patient had a left-sided third cranial palsy. At this time, diagnosis of MS was made because there were some demyelinating lesions in the midbrain and thalamus. But this area is not typical for MS. This is relatively deeper areas in the, not in the white matter, but in the deep midbrain areas. Okay, so and in 2006, patient had recurrent episodes of ataxia and vomiting. So still the patient had a diagnosis of MS, came to us with acute vision loss. You can see vision is very bad in both eyes and the rest of the anterior segment was fine. Only confrontation visual fields were possible at that time and which were constricted. As the patient was a known case of multiple sclerosis, we thought that patient had a demyelination episode and we thought of two possibilities, recurrent episodes of optic neuritis and neuromyelitis optica. We ordered the patient be treated with IV methylprednisolone as per ONTT, but ordered MRI brain and cervical spine. With IVMP, patient's visual acuity started improving over a period of few months, and we could obtain visual fields over here where we can see actually a bitemporal depression, which is suggesting that the patient possibly had a lesion in optic chiasm. However, MRI brain was relatively normal, excepting the fact that we could see some hyperintense lesions in the optic nerve, but MRI spine showed the actual pathology. We could see that there is presence of multiple areas of spinal cord enhancement, which is contiguous. These are called as longitudinally extensive transverse myelitis. That is, contiguous more than 3 spinal segments are showing the pathology. Then the diagnosis was most likely neuromyelitis optica, and we obtained serum aquaporin antibodies which are positive. So this is a classical example of a patient with neuromyelitis optica. So we saw two different examples here. One was multiple sclerosis, one is NMO. So in a MS, you see involvement of white matter of brain as well as optic nerve. The involvement of spinal cord might be there, but in all short segments of optic nerve. Whereas in the CSF, you will see CSF oligonal bands might be present. Whereas in NMO, you see that the brain and spinal cord, brain might be relatively normal, but spinal cord and optic nerve are affected. We see multiple contiguous areas are involved in the spine, which are called as longitudinally extensive transverse myelitis, and in the CSF we will see CSF pleocytosis with polymorphonuclear cells. And you can confirm the diagnosis by doing the serum aquaporin antibodies. Why it is important to distinguish between NMO and MS? Because the pathology is different. In NMO there is much more damage and it's not demyelination. Even though the acute phase treatment might be similar with IV steroids, but definite treatment is different in both the diseases, and definite treatment given for MS such as interferon, natalizumab can actually worsen the course of NMO. Therefore, it is important for us to distinguish between them. We can consider diagnosis of NMO even in the first episode of optic neuritis if there is severe vision loss, if there is poor visual acuity, if there is prolonged vomiting and hiccups, if there is chiasmal neuritis, like in the patient with visual field we saw there was bitemporal hemianoptic field defect, if there is simultaneous bilateral involvement and long segments of optic nerve are involved. Sometimes we see patients showing multiple areas of demyelination in the brain, which are not classical of MS. This patient is actually a patient with HIV optic neuritis. Sometimes you might see in a patient with optic neuritis diffuse confluent lesions. These are suggestive of acute disseminated encephalomyelitis, edema. Okay, so these patients should be worked up in a different way. And in children, if you see pathology like edema, the thing which you should keep in mind is a emoji optic neuritis. These patients have optic nerve involvement, which is usually bilateral and tends to have multiple round to oval lesions, which are present in different areas of the brain, in the white matter as well as in the deep white matter areas. And these patients are positive for emoji optic neuritis. This is a very important picture which shows classical differences between three important diseases: MS, NMO, and MOG. In MS, we see that there is optic nerve involvement in one side only. The spinal cord involvement is short segments, and they are involving the lateral and the anterior horns of the spinal cord, and there are multiple white matter lesions. which are in the subcortical area, periventricular area. There can be white matter involvement in the cerebellum. Whereas in emerging optic neuritis, you see usually bilateral involvement, but the chiasm is not involved. The spinal cord is involved in the lower segments, like as lumbosacral, and there is involvement of area postrema, which can cause vomitings in these patients. In NMO, there is usually bilateral involvement, which is long segments. There can be involvement of optic chiasm, and there is cervical and thoracic cord which is involved, but the lesions are again very contiguous. More than 3 segments are involved, and there can be periependymal lesions which can be involved in the in the areas where aquaporin is manifesting. So this is important to know for us and to distinguish in a patient with optic neuritis. The message for us should be that when we are seeing a patient with optic neuritis, it should not just be a diagnosis of optic neuritis and treat with ONTT, but to find out what is the underlying cause. Is it isolated? Is it post-vaccination, post-febrile illness, post-viral illness, or is it something which is systemic like multiple sclerosis, NMO, and emerging optic neuritis? That's very important. So I think if time is up, we can conclude with this thing, that we should take always a focus history, do a well-directed examination, revisit subtle findings in the patient with optic neuropathies, localize whether it's optic nerve alone, orbit, brain, diffuse pathology, and then perform the appropriate investigations in these patients and keep alive the little detective in us. Thank you very much. I will stop here. Otherwise, if you all want, we can discuss.
You have a question. Abhishek, you want to ask, unmute and ask something?
So we have covered basically about approach to optic atrophy, about evaluating patients with optic disc edema, unilateral versus bilateral, IIH, CSVT. We have covered a little bit about optic neuritis in different settings. And I can tell in brief about NAION as well if you all want. That will cover majority of the spectrum of the optic neuropathies.
That will be nice. It will be nice. You can cover it.
Yeah, sure. Okay. Don't see any questions as of now, but we'll go ahead with the. So this is a patient who is a 59 years old female who presented to us.
Slide, Dr. Virendra.
You're not able to see? Okay. Let me know if you are able to see.
Not yet.
Yeah, I'm sharing. Are you able to see now?
Yes.
Okay. So let's see the history of this patient. It's a 59 years old lady who presented to us with gradual decrease in vision in right eye for 8 days. There was no visual complaint in the left eye. Importantly, the patient was non-diabetic and hypertensive, and she was on treatment for last 6 years. The recently available records of her blood sugar showed that they were fluctuating a bit. Fasting was 177, postprandial was 238. This is the examination. The patient's visual acuity was only hand movements in the right eye, and left eye it was 20/20 and 6. Anterior segment was normal except for grade 3 relative afferent pupillary defect in the right eye. And this is the fundus picture. Again, media is clear, the retina is fine, but we see an optic nerve edema. You can see that there is actually presence of splinter hemorrhages on the surface of the disc, and you can see here there is blurring of the peripapillary RNFL obscuration. Importantly, you see that there is attenuation of blood vessels. So this patient, given this picture, we will start thinking that most likely in an older patient with vasculopathic risk factors, we are looking at possibly acute non-arthritic anterior ischemic optic neuropathy. Slowly, the patient was managed conservatively, and what we did was the patient was imaged once to rule out any other neurological problems, but the patient was asked to keep strict control of hypertension and diabetes. Slowly, the patient's disc edema resolved, and this is the visual acuity of the patient at 6 months follow-up. We can see that this is a post-NAION optic atrophy. There is presence of diffuse disc pallor with attenuated blood vessels. The fellow eye is quite okay, and few days later, 1 month later, the patient came with the involvement in the other eye, and this patient had a recurrent NAION. Now, the important thing in a patient with NAION is the control of risk factors. Risk factors are the same for involvement in one eye and in the fellow eye. You look at the vasculopathic risk factors. Importantly, look for diabetes, dyslipidemia, hypertension, coronary artery disease, any history of obstructive sleep apnea. Look for anemia, which could also be causing a sluggish circulation. Look for the ocular risk factors such as optic disc lucens, glaucoma, and vein occlusions, which can precipitate the episodes of acute vision loss in these patients. Now, this is a visual fields of the same patient. We can see that in the right eye with the optic atrophy, there is diffuse field loss, and we are able to do fields only with the stimulus 5. Whereas in the left eye, you can see a inferior altitudinal field loss, which is highly typical of a non-arthritic anterior ischemic optic neuropathy. We have some tools for helping us in diagnosis of NAION. For example, we can do the OCT angiography. This is an article published from LVPEI Institute, where you can see that in a normal eye how the perfusion appears, whereas in a patient with papilledema we can see that there is reduction in perfusion. This article showed specific changes which might be seen in a patient with NAION. You can see that there are areas of capillary dropout where there is diffuse perfusion. There is a perfusion loss, and sometimes you might also see areas of capillary dropout which are extending linearly apart from the area of the disc edema. And if you see these might be corresponding to the field loss in these patients. So this is highly suggestive of acute perfusion loss in the posterior ciliary circulation that is causing the NAION as well as a field defect. In some patients, there are some articles which tell us if we do a dedicated orbital imaging, we might be able to pick up some problems in these patients. In a patient with optic neuritis versus NAION, this article tells what are the differences. In a patient with NAION, you might be able to see a hyperintense lesion only on the surface of the optic nerve, and then you might be able to see that the rest of the optic nerve is fine. Whereas in a patient with optic neuritis, we see that there is post-contrast enhancement, that is post-contrast, and after the administration of contrast, there is enhancement in the optic nerve, as well as there is a diffusion restriction in the optic nerve itself. So this is one technique which can help you diagnose NAION. How do you treat a patient with NAION? So as of now, till date, there is no definite treatment that is available for treatment of acute NAION. But what is reported is that the surgical decompression, we give oral or IV steroids, intravitreal steroids, peripurpose steroid injection, everything has been tried. It is said that it's like a disease which does not have a definite treatment, but has been proposed to be treatable in multiple ways. What definitely holds true is that in these patients, you control the vasculopathic risk factors and prevent the disease from occurring in the fellow eye as well as in the rest of the body like a stroke. So the landmark treatments have been the steroids. This is a study by Dr. Sohan Singh Here, which is the basis of doing this treatment. And in a large study, he showed that when the patients were treated with oral corticosteroids, there was improvement in best-corrected visual acuity by more than two lines in 70%, versus no treatment, patients had only 40% chance of improvement. Similarly, there was improvement in visual fields. So this study formed the basis of the treatment with steroids. However, steroids have their own side effects. They can increase diabetes, they can fluctuate the blood pressure of the patient. Therefore, if patient has labile hypertension and labile blood sugar levels, it is not a recommended treatment. In a recent study from AIMS, Dr. Rohit Saxena and their colleagues, they showed that when the steroids were given versus no steroids were given, there was no significant improvement in the visual acuity of these patients. Therefore, this study actually shows that there is no definite benefit of giving steroids in these patients. There is another study which showed that if you are treating a patient with Avastin, especially with macular subretinal fluid, there might be flattening of the macula and improvement in the visual acuity. So, apart from this, our little experience also tells that if you are treating with intravitreal VEGF in these patients, there might be reduction in the edema, and these patients might have a relatively better visual acuity at 6 weeks and 3 months follow-up as compared to no treatment versus oral steroids. The recent treatment proposals have been in form of two landmark trials. One is called as a QARC NAION study, which is called QRK207 study. In this, they tried to treat the patient with acute NAION with an intravitreal injection of a drug called QPI 1007. It's a caspase inhibitor and inhibits the apoptosis following the insult. So the study was concluded last year, and the study showed that there was no safety concern, but an interim analysis has been done, and it shows some promising results in preventing visual loss, but the final results are still not published until now. There is another trial which is going on, which is called a trial with RPH 201, so which might show in future that whether the patients are benefiting by giving this drug in the future or not. So there is a lot happening in the research about treatment of acute NAION, but what remains the mainstay is that we identify the risk factors, look for at least 6 things: diabetes, hypertension, dyslipidemia, hyperhomocysteemia, coronary artery disease, and hypercoagulable states. If any of these is there, we treat the patient with these things and then help the patients by keeping them in close follow-up and prevent secondary involvement. So I hope this gives you all a good clinical approach about most of the common optic neuropathies. If you have any questions, I am happy to answer and we can discuss further.
Thank you so much.
You are welcome, sir.
Anybody would like to unmute and ask directly?
Hello, sir. Sir, as you said in NAION, you do investigations to rule out any other neurological complaints.
Yes.
What are these investigations? For example, in optic neuritis, we do MRI with contrast. What these all investigations will be done in NAION also?
If you have a classical patient, say you have a patient who is meeting the age group of the more than 45, 50, the other eye is actually showing a small disc, which is like a disc at risk. Then, and there is definite vasculopathic risk factors, possibly MRI is not needed. But if you have a patient who has a variable presentation at a borderline age, possibly MRI is definitely indicated. And as I showed that you can see the pathology in these patients. Like you can see the lesion in the DWI images of the patient on the optic nerve and in the optic nerve head. So that's how you can pick up. So not all patients, but selected patients, definitely MRI should be done. Okay. Any other questions? You know, it's a very broad topic and it's difficult to cover each thing in very detail. But if you people have any questions, you can always send me through my email and I'll be happy to answer and I'll be happy to share. I think one of the good resources that you should all can look at, which is given in a very exciting way, is a book called Neuro-Ophthalmology Illustrated. It is not a very expensive book and it's not a very big book. So you can get a very good approach of common neuro-ophthalmological diseases. Similarly, in postgraduate ophthalmology, there are many good chapters on neuro-ophthalmology. You can go through that also. It will help you. If you all follow Jacobic or Yanov, that also gives a very good approach to common diseases. That will help you.
So we don't have any more questions, and we have had a very nice presentation from you, nice interaction. We would like to thank Dr. Virendra Sachdev for that wonderful presentation today on common optic neuropathies, and I'm sure everybody benefited. And later also, when postgraduates see this, it will be a good revision for them before their exam. I would like to inform all the postgraduates that tomorrow Dr. Digvijay will be speaking on visual field quiz. Though we have written quiz, but it's not a quiz, it will be like a presentation and an interaction about the different visual fields and how you go about making a diagnosis. So we'll meet you all again tomorrow at 5 p.m. Once again, I would like to thank Dr. Virendra Sachdeva for this wonderful presentation. I would also like to thank Intas Pharmaceuticals for bringing this all together. I'd like to thank Manish ji and Chandrasekhar ji. And Dr. Sachdeva, really thank you so much for bringing this all together, for all the efforts you have put in today.
Thank you so much. Nice to connect you all.
Thank you so much. Thank you so much. We look forward to meeting you sometime.
Yeah, definitely.
Thank you.
Stay
so
safe.
much. Okay, we'll see you tomorrow. Thank you. Bye.